Good evening, everyone. I think we should start now. This is a continuation of the series of lectures that we've been having over the last couple of weeks. We discussed about the embryology, the embryogenesis of the vessels. And today, I think Rohit is going to discuss with us about the carotid system, the internal and the external carotid arteries, the origin, the branching, and various aspects of that. So over to you, Rohit. Please start.
Good evening, everybody. I'll be presenting about carotid artery embryology, development, and then anatomy. So in this session, I'll be discussing about the carotid artery development, embryology, and also carotid system and internal carotid artery and external carotid artery anatomy and their branches. So first thing is coming to the embryology part. So during the developmental phase of 4th and 5th week, when the pharyngeal arches form, the aortic sac gives rise to the arteries known as the aortic arches. These aortic arches are the endothelial lined dilation and primordial vascular channels from which the aortic arches arise. In the initial stage, these aortic arches are formed in pairs, which are numbered as 1, 2, 3, and 1, 2, 3, 4, 5. And later during the developmental phase, the first, second, and fifth pairs disappear. And these aortic arches, they usually are short vessels connecting the ventral and dorsal aortae on each side. They run within the branchial arches, and they're totaling of 6 pairs, of which 3 pairs disappear later. And coming to the development of the arteries, the ventral part of the aortic sac, left horn, and the left fourth arch artery form the arch of aorta. The right horn of the aortic sac forms the brachiocephalic or innominate artery. The right fourth arch forms the proximal part of the right subclavian artery. On the left side, the subclavian artery is mainly derived entirely from the 7th cervical intersegmental artery. The common carotid and subclavian arteries become the branches of brachiocephalic artery. The external carotid artery arises as a bud from the 3rd arch artery. The pulmonary arteries are derived from the part of the 6th arch arteries. And coming to the common carotid artery, the right common carotid artery is a branch of brachiocephalic trunk, and it begins in the neck behind the right sternoclavicular joint. Left common carotid artery is the branch of arch of aorta, and it begins in the thorax in front of trachea, a little left to the center of manubrium. At the level of upper border of thyroid cartilage, that is approximately at third or fourth vertebrae, cervical vertebrae, the arch divides into external and internal carotid arteries. So there are some variations in the common carotid artery bifurcations. So most common level of bifurcation will be at the level of C3 and C4, which account up to 30 to 35% of the total bifurcation levels. And rarely they may arise at the level of C2 and also at the lower border of the C5 vertebrae, which are very rare. And carotid, common carotid artery, mainly it has 2 systems, carotid sinus and body. The termination of common carotid artery or beginning of internal carotid artery shows a slight dilation known as the carotid sinus. It acts as a baroreceptor and also regulates the blood pressure. Carotid sinus hypersensitivity is an exaggerated response to carotid sinus baroreceptor stimulation. It results in dizziness or syncope from transient diminished cerebral perfusion. For these individuals, even mild stimulation to the neck results in marked bradycardia and drop in blood pressure. The carotid body is a small oval reddish-brown structure situated behind the bifurcation of common carotid artery. It receives nerve supply from the glossopharyngeal and vagus nerve. It acts as a chemoreceptor and responds to mainly change in the oxygen carbon dioxide levels in the body. And next comes the internal carotid artery. The origin is mainly at the upper border of the thyroid cartilage at the disc level of 3rd or 4th cervical vertebra and ascend to reach the base of the skull where it enters the carotid canal. So this is the classification schemes of the internal carotid artery. The earliest was the Fisher classification, However, it is of not use in now. And the most common divisions mainly used as of now is Givo classification and Boutiller classification. In Boutiller classification, it is the internal carotid artery is mainly divided into 7 segments. These segments I'll be discussing in the coming slides. And most commonly, most of the neurologists follow the Givo classification scheme, where internal carotid artery is divided into only 4 segments, and which is easier to follow also. So coming to the first segment, it is known as cervical segment. It begins at the carotid bifurcation and ends in the skull base. This segment doesn't have any branches, and it mainly receives 80% of the supply from the common carotid artery. And it has mainly 2 divisions. One is the carotid bulb and ascending cervical segment. Ascending cervical segment is the lengthier part, and it also has variants mainly based on the position of origin, where the bifurcation can be as high as C1 and also as low as up to T2 vertebrae. And sometimes we can see the carotid as being hypoplastic and also sometimes agenetic, and also congenital absence and hypoplasia of the high CS were also reported. And agencies of internal carotid artery has a prevalence of 0.01%, whereas bilateral ICA agenesis is seen up to less than 10% of ICA agenesis cases. And ICA hypoplasia has an incidence rate of 0.079%. Next, coming to the petrous segment, it has mainly a vertical segment and horizontal segment. It extends from the opening of carotid canal in the skull base to the posterior edge of foramen lacerum. The vertical subsegment transitions into horizontal subsegment via the genu of the petrous ICA, that is a bend, 90 degrees bend in the vessel. The vertical segment average length is up to 1 centimeter, whereas the horizontal, which is the lengthier of the two, is averages up to 2 centimeters. And it itself has little branches which are visible only in 23% of angiographic cases. It has mainly periosteal branch, which arises at the entrance of the ICA into the carotid canal, and caroticotympanic artery, which arises from the petrous ICA near the genu and travels superiorly and posteriorly to the middle ear cavity, and a Vidian artery, which is a small branch arising from the horizontal petrous ICA and travels anteriorly within the pterygoid canal to the pterygopalatine fossa. And its variants include aberrant ICA, where the ICA enters the temporal bone posterior to external artery meatus, ascends between the facial canal and jugular bulb, and passes within the middle ear cavity. So this may present as a pulsatile mass, and it should be kept in mind to avoid potential disastrous biopsy procedures. And another variant is persistent stapedial artery, which prevalence marks up to 0.48%. The persistent stapedial artery arises from the petrous ICA, which passes through the middle ear and continues as middle meningeal artery. So in this picture, you can see that this persistent stapedial artery, which is marked by the white arrows. And the next segment is the laceran segment. It is a short part of the artery that extends from petrous ICA to the cavernous segment over the foramen lacerum. The foramen lacerum is approximately 1 centimeter long and is filled with fibrocartilage amounting to the closed pore over which the ICA passes. It doesn't have any subsegments, branches, and variants. Next comes the cavernous segment. It is a S-shaped and extends from superior margin of the petrolingual ligament through the cavernous sinus to the proximal dural ring. This portion of the ICA is mainly surrounded by areolar tissue, fat, postganglionic sympathetic fibers, and interconnecting venous chambers of the cavernous sinus. The cavernous ICA also travels directly adjacent to the wall of sphenoid sinus. A layer of bone less than 0.5 millimeter thick separates the artery from the sinus in almost 90% of cases. And sometimes a complete absence of bone between the artery and sinus is present in nearly 10%, which is a variant. And it has mainly the branches of the cavernous segment of ICA are mainly divided into 3 types, mainly based on the course. The one which is posterior trunk, where it gives rise to the tentorial artery, inferior hypophyseal, and dorsal meningeal artery, and the lateral trunk, which gives rise to anterior medial branch, anterior lateral, and posterior branches. The medial part is not shown here. And the cavernous segment of the ICA forms a greater part of the carotid siphon. The carotid siphon is the S-shaped part of the to the ICA. It begins at the posterior bend of cavernous ICA and ends at the ICA bifurcation. It can have either an open configuration or a closed configuration, which has an implication for the ease of endovascular navigation in this region. As I have already told, mainly the branches are divided into three groups, known as posterior and lateral trunk and medial group. So the posterior trunk, also known as meningohypophyseal artery, arises from the posterior bend of the cavernous ICA. It gives rise to tentorial branch, inferior hypophyseal artery, dorsal meningeal artery, the branches of which supply the dura around the Doralus canal, superior clival dura, and abducens nerve. The lateral trunk arises from the lateral aspect of the horizontal segment and travels superior to the abducens nerve to supply cranial nerves within the cavernous sinus. The medial branch group arises from the most superior portion of the cavernous segment and supplies the pituitary gland. Other cavernous ICA branches include ophthalmic artery, which may be a variant, and it is found to arise from the cavernous segment instead of ophthalmic segment, which is seen in 8% of the cases. And other variants of cavernous ICA include kissing intracellular ICAs. The cavernous ICA may extend beyond the medial wall of cavernous segment and runs medial in the sella tursca. These ICAs approach within 4 millimeters of each other within the sella, and then seen up to 10% of the cases. And intercavernous ICA anastomosis, which occurs in hypoplasia or agencies of ICA, where a large collateral vessel connects the cavernous carotid artery. And the next segment is the clinoidal segment. It comprises of a tiny wedged shaped part of ICA between the proximal and distal dural rings. It doesn't have any subsegments. Mainly, ophthalmic artery may arise from the clinoidal segment in rare cases. It doesn't have any variants. And coming to the ophthalmic segment, so mainly the ophthalmic segment branches include ophthalmic artery, which is a major artery, and others include perforating branches and superior hypophyseal artery. The ophthalmic artery arises from the anterior aspect of the ICA, medial to the anterior clinoid process. The vessel originates distal to or at the distal of dural ring in 90% of cases. In about 8%, it may arise from the cavernous segment, which is a variant. And ophthalmic artery itself has many branches. The branches are highly variable and have variable anastomosis with the external carotid artery, which are extensive. So the branches of ophthalmic artery include recurrent meningeal arteries, posterior ethmoidal artery, muscular branches, central retinal arteries, ciliary arteries, lacrimal arteries, and anterior Fox arteries. And next comes the communicating segment. The communicating segment begins just proximal to the origin of the posterior communicating artery and ends with the bifurcation of internal carotid artery. The branches of the communicating segment mainly include posterior communicating artery and anterior choroidal artery. Posterior communicating artery arises from the internal carotid artery and travels posterior medially to join the posterior cerebral artery at the junction between P1 and P2 segments. It itself gives number of perforating branches ranging from 4 to 14. And these branches terminate in the floor of third ventricle, posterior perforated substance, optic tract, pituitary tract, and optic chiasm. These perforators reach the thalamus, hypothalamus, and internal capsule. These arteries are called as anterior thalamoperforators to distinguish from the perforated branches that arise from the P1 segment. The variants of the PCOM include persistent fetal origin, where a fetal configuration where a PCOM artery arises directly from the ICA and has the same diameter of the P2 segment of PCA. And another variant is infundibulum, a funnel-shaped origin of the PCOM artery, and hypoplasia. And if you, in this picture, if you can see the PCOM arising directly from arising from the internal carotid artery, and which continues as the posterior cerebral artery. So you can notice the size of the PCOM as large as the P2 segment of the PCA. And another branch of C7 segment is anterior choroidal artery. It arises mainly from the posterior lateral aspect of the ICA. It has mainly two segments, that is cisternal and intraventricular segment. In this picture, the anterior choroidal artery is mainly marked by the black arrow, and down to it is the PCOM branch, which is marked by the white arrow. These two are the main branches of the C7 segment. The brain structures irrigated by the branches of anterior choroidal artery include optic radiation, globus pallidus, midbrain, thalamus, and posterior limb of internal capsule. Occlusion of anterior choroidal artery produces characteristic triad, that is contralateral hemiplegia, hemianesthesia, and hemianopia, along with that memory loss and somnolence. The variants of anterior choroidal artery include one is ectopic origin, where it may origin from the middle cerebral artery or posterior cerebral artery. Absence of anterior choroidal artery can also be seen sometimes, or hyperplasia. And next part of the discussion is external carotid artery and its branches. So external carotid artery mainly supplies much of the soft tissue and bony structures of the head and face, deep structures of upper aerodigestive tract, and much of the dura of the intracranial compartment. Numerous anastomoses are present between ECA branches and branches of internal carotid and vertebral artery. And its main course and relation, it begins with in the carotid triangle at the level of upper border of the thyroid cartilage, and that is at the level of C3 or C4. It runs upwards and slightly backwards laterally and terminates behind the neck of the mandible, mainly by dividing into maxillary artery and superior temporal artery. The variants, the most frequent branching pattern is it arises anterior medially, whereas the internal carotid arises posterior laterally. However, occasionally you can see that ECA can arise as posterior laterally or direct laterally. And sometimes ECA and ICA may arise as separate branches from the arch of aorta. Rarely, all external carotid branches may arise from the internal carotid artery, or sometimes it can arise as a common trunks with other branches, including which include a linguofacial trunk, thyrolingual trunk, thyrolinguofacial, and occipito-auricular trunks. In the internal carotid, in the carotid triangle, it is superficially related to cervical branch of the facial nerve, hypoglossal nerve, superior thyroid veins, whereas deep to the artery are situated are wall of the pharynx, superior laryngeal nerve, ascending pharyngeal artery. And above the carotid triangle, it lies deep to the substance of carotid triangle. Superficially lies the retromandibular vein and facial vein, and deep to the artery lies the internal carotid artery. And the structure in this region, the structures passing between external and internal carotid artery include styloglossus, stylopharyngeal muscles, 9th pharyngeal branch of 10th nerve, and styloid process. So the branches of external carotid are mainly 8 major branches, by the which are mainly superior thyroid artery, which runs down, ascending pharyngeal artery, which ascends up vertically, lingual artery, which supplies mainly the tongue, facial artery, posterior auricular artery, maxillary artery, occipital artery, and superficial temporal artery. So coming to the branches, the first branch include a superior thyroid artery. It arises just below the level of greater corner of the hyoid bone. It runs downwards and forwards deep in the infrahyoid muscles to the upper pole of the thyroid gland. The superior laryngeal artery supplies the pharyngeal and laryngeal structures as well as internal laryngeal nerve. It anastomoses with its contralateral partner and with the inferior laryngeal artery from the inferior thyroid artery. So the branches of superior thyroid artery include infrahyoid branch, which runs along the lower margin of the hyoid bone, and superior laryngeal branch, which pierces the thyroid membrane and enters the larynx. Cricothyroid branch, which runs across the cricothyroid membrane to anastomose with the artery of opposite side, and anterior thyroid branch. Other branch includes sternomastoid branch, which runs backwards of the common carotid. And mainly the applied anatomy of the superior thyroid include intraarterial infusion chemotherapy for laryngeal and hypopharyngeal cancers. And also it has variations of origin. So a total of, in a study, a total of 25 angiograms were evaluated, including 14 right and 11 left. On the right, superior thyroid artery was noted to arise from ECA in 71%, or sometimes it may be seen arising from the bifurcation of common carotid or from the common carotid artery. On left side, the left superior thyroid artery was seen to arise from the ECA in 72%, and sometimes seen from the bifurcation of common carotid artery and internal carotid artery. Next branch is the lingual artery. The lingual artery arises from the ventral aspect of the external carotid and takes a gentle anterior inferior path. It creates a characteristic U-shaped curve. That is how it is identified also anatomically. And it's mainly based on its course, it is divided into three parts by the hypoglossal muscle. The first part lies in the carotid triangle. The second part lies deep to the hypoglossal muscle. Third part runs along upwards and along the anterior margin of the hypoglossal muscle. The branches mainly include suprahyoid branch, which runs along the hyoid's upper border. Deep lingual, dorsal lingual branch, which arises medial to hyoglossus to supply the tongue. Palatoglossal arch, tonsil, soft palate, and epiglottis. Sublingual artery supplies the sublingual gland, mylohyoid, and the lingual gingival mucous membrane. Deep lingual artery, it is a terminus of the lingual artery. It passes along the ventral aspect of the tongue, accompanied by the lingual nerve to its apex. So the variations in the origin of lingual artery has been documented in various articles. Sometimes it is seen arising from the common carotid or from the linguofacial trunk. The lingual artery provides generous arterial supply to the tongue and floor of the muscle. There are anastomosis with the contralateral lingual artery and ipsilateral facial arteries via the submental branches. The next branch is a facial artery. It is a chief artery of the face. It arises from the external carotid artery just above the greater cornea of the hyoid bone. It has two parts, mainly cervical and facial part. At the anterior inferior angle of the masseter muscle, it can be palpated here and is known as anasthetis artery. So mainly the facial artery is characterized by its tortuous course, which allows free movements of the pharynx during deglutition and also free movements of the face, free movements of the mandibles, lips, and cheeks during mastication and facial expression, which escapes the traction and pressure during the movements. The mainly it is divided into two segments. First comes the cervical part, where the branches in the cervical part include ascending palatine artery, which supplies the levator velar palatini, superior pharyngeal and neighboring muscles, soft palates, tonsil, and auditory tube, and tonsillar branch, which supplies the palatine, tonsil, and posterior tongue, and submental artery, which arises from the facial artery near the anterior border of the masseter muscle. It accompanies the mylohyoid nerve and supplies the submental triangle and sublingual salivary gland, and the glandular branches, which supply the submandibular salivary gland and submental lymph nodes. And the branches of facial part include superior labial and inferior labial. Superior labial passes superior to the orbicular oris muscle and supplies the upper lip, and anterior inferior part of nasal septum. Inferior labial originates near the corner of the mouth and passes deep to the depressor angular oris and supplies the lower part of the lip. Lateral nasal, which supplies to the ala and dorsum of the nose. Angular, which supplies the lacrimal sac and orbicularis oculi. And next a branch of the ECA is ascending pharyngeal artery. It is a small branch arising from the medial side of the external carotid artery. It is a long, slender, and deeply seated in the neck. It runs vertically upwards between the side wall of the pharynx, tonsil, and medial wall of middle ear and auditory tube. You can see the small artery arising, which ascends upwards along with external carotid artery. It is a long and thin artery. So even though it is of a smaller size, it has branches which mainly include inferior pharyngeal artery, which supplies the pharyngeal muscles and mucosa, musculospinal artery, which may arise from the ascending pharyngeal itself or from the neuromeningeal trunk. It extends posteriorly and superiorly for short distance before curving inferiorly. Neuromeningeal trunk, which is a major branch and that continues cephaloid, and prevertebral artery, which occasionally this artery arises directly from ascending pharyngeal artery and contributes to the odontoid arcade. Other branches include hypoglossal branch, jugular branches, and inferior other branch is inferior tympanic artery, which supplies the middle ear cavity and associated nerves, including the 12th nerve and the tympanic branch of 9th cranial nerve. Middle pharyngeal artery, which supplies the mucosa and muscles of naso and oropharynx as well as soft palate. Superior pharyngeal artery, which supplies upper nasopharynx, including the orifice of the eustachian tube, as well as associated muscles, including superior constrictor. It has many potential. The ascending pharyngeal artery, it has potential anastomosis, which include accessory meningeal, pterygovaginal, and contralateral superior pharyngeal. If a VDN artery is present, this is a potentially dangerous anastomosis during the embolization procedures, and it may contribute to cavernous carotid fistulas via the pitras internal carotid artery. And applied anatomy include in epistasis, ascending pharyngeal artery embolization plays an increasing role in management of epistasis. In high-grade head and neck tumors, intra-arterial embolization, that is super selective microcatheter infusion of ascending pharyngeal artery, is necessary for successful embolization. And in vascular lesions at the skull base, the ascending pharyngeal artery can be a major feeder to AV malformations and AV fistulas. And it can also happen to be a collateral to agenetic or occluded internal carotid artery. And the ascending pharyngeal artery can also be recruited in case of an occluded internal carotid artery. Next branch of external carotid artery is posterior auricular artery, which arises from the posterior belly of digastric and which progresses upwards and backwards behind the auricle. Its branches include stylomastoid, auricular, occipital, sternocleidomastoid, parotid arteries. The stylomastoid artery, it mainly supplies the facial nerve, tympanic cavity, mastoid antrum, air cells, and semiauricular canals. Auricular branch, which supplies the auricle. Occipital branch, which anastomoses with the occipital artery. It supplies the occipital belly of the occipital frontalis muscle and scalp above and behind the ear. And the sternocleidomastoid branch, which provides a blood flow to the sternocleidomastoid muscle, digastric, and stylohyoid muscles. Parotid branches, which supply the portion of the facial nerve. And next is the next branch of the ECA is occipital artery, which arises from the posterior part of the external carotid and opposite to the facial artery. It ends in the posterior part of the scalp. It sometimes the variant origin may be seen from the internal carotid artery. The branches based on the anatomy, it mainly includes a carotid triangle and the posterior triangle. In carotid triangle, two branches of sternomastoid are seen. Upper branch, which accompanies the accessory nerve, and lower branch arises near the origin of occipital. Sir, hello. Hello.
Are you there?
Yeah, I'm there, sir. Are you able to hear me? Hello.
Rohit, are you there?
Yes, sir, I'm there. Are you able to hear me?
Yeah, better now. Continue.
Okay. So the mainly branches of occipital artery are based on the anatomical division. So branches based on in the carotid triangle and posterior triangle. In carotid triangle, two branches are seen. These are sternomastoid branches, which supply the sternomastoid muscle. In the posterior triangle and the scalp region, mainly auricular branches, mastoid branches, meningeal branches are seen. The auricular branches passes superficial to the mastoid process and reach and supply to the back of auricle. Mastoid branch to supply the mastoid air cells. Meningeal branch, which supplies the dura of the posterior cranial fossa. Muscular branches which supply the digastricus, stylohyidus, splenius, and longissimus muscles. Descending branches where it divides into superficial and deep portions. The superficial portion supplies the trapezius, and deep portion supplies the semispinalis, capitis, and colli. So you can see the occipital artery course, which arises and ascends upwards and backwards, and ends at the scalp of the occipital region, where it is found to anastomose with some of the occipital branch of the posterior auricular artery. And next artery is the maxillary artery, which is the larger of the two terminal branches of external carotid artery. It arises behind the neck of the mandible and is embedded in the substance of parotid artery, a parotid gland. It mainly supplies the deep structures of the face. So based on its course and relation to the structures, it is mainly divided into three parts. And each part has its own divisions and branches. The first branch is the mandibular branch, which lies medial to the mandible, passes between the ramus of the mandible and sphenomandibular ligament, where it lies parallel to a little below and to a little below auricular temporal nerve. It crosses the inferior alveolar nerve and runs along the lower border of the lateral pterygoid. So its branches include mainly deep auricular artery, anterior tympanic artery, middle meningeal, which is a major branch, accessory meningeal artery, and inferior alveolar artery. So first I will be discussing about the middle meningeal artery. It is also known as menidural branch. It is the largest artery that supplies the dura. It ascends between the sphenomandibular ligament and the lateral pterygoid muscle between the two roots of auricular temporal nerve to the foramen spinosum, through which it enters the middle cranium. It mainly divides into anterior branch and posterior branch. The anterior branch, also known as frontal branch, it is mainly it crosses the great wing of the sphenoid, reaches the groove, and in the sphenoidal angle of parietal bone, and then divides into branches which spread out between the dura mater and internal surface of the cranium. Posterior branch or parietal branch, which goes backward on the squam of temporal bone and divides into branches which supply the posterior part of the dura mater and cranium. And next is the next sub branch of the maxillary. First part of the branch is inferior alveolar artery. It mainly descends with the inferior alveolar nerve to the mandibular foramen on the medial surface of ramus of the muscle, mandible. It runs along the mandibular canal accompanied by the nerve and opposite the first premolar tooth, which divides into branches of incisor, and mental. So incisor is continued forward beneath the incisor teeth as well as midline, where it anastomoses with the opposite side artery. Mental branch, which supplies the chin and anastomoses with the submental and inferior labial arteries. So this is the course of the inferior alveolar artery, which runs along downwards and then also divides into or subdivides into dental and mental branches. So before entering the mandibular canal, it supplies a lingual branch to the tongue and mylohyoid branch to the mylohyoid muscle. And within the mandibular canal, it gives branches to the mandible, branches to the roots of each teeth up to midline, and incisor branch which anastomoses with the opposite branch. And after emerging from the mental foramen, it gives up the mental branch which supplies the chin, anastomoses with other submental and inferior labial arteries. And the second part is the pterygoid part, which runs forward and upward superficial to head of the lateral pterygoid muscle. It gives rise to posterior deep temporal, pterygoid artery, anterior deep temporal, buccinator, mesenteric, and pterygoid arteries. And the third part, the terminal branch, is the pterygopalatine branch, which passes between two heads of the pterygoid muscle and it gives rise to the descending palatine, pharyngeal, artery of pterygoid canal, spinopalatine, infraorbital, posterior superior alveolar arteries. Inferior infraorbital artery mainly arises before the maxillary artery enters the pterygomaxillary fissure. It runs along the infraorbital groove and canal with the infraorbital nerve and emerges on the face through the infraorbital foramen beneath the infraorbital head of the quadratus labii superioris. Superficial temporal artery. This is the last branch of the external carotid artery. It begins in the substance of the parotid gland behind the neck of the mandible and divides into two branches, a frontal and parietal branch. It runs vertically upwards, crossing over the root of the zygomatic process. About 5 centimeters above this process, it divides into frontal and parietal branch. Relations include mainly when it crosses the zygomatic process, it is covered by auricularis anterior muscle and by dense fascia. It is crossed by temporal and zygomatic branches of facial nerve and is accompanied by auriculotemporal nerve, which lies immediately behind it. So it supplies perforating branches to the auricle, and it also has many branches, which include a transverse facial branch, anterior auricular branch, frontal branch, parietal branch, zygomatic orbital branch, and middle temporal branch. Territories. The superficial temporal is a major contributor of the blood flow to the scalp and is in hemodynamic equilibrium with occipital and posterior auricular arteries. Variants include, it varies based on the size and territory. Always hemodynamic balance exists between the individual superficial temporal artery branches and competing scalp arteries. Therefore, when one artery is large and covers a wide territory, adjacent arteries may be small or even absent. That's all. Thank you.
That was a fairly exhaustive presentation. Now, my comments on this presentation, basically what I would like to say is, whenever you discuss anatomy, whenever you study anatomy, there are two ways of studying anatomy. One way is what we call as descriptive anatomy, what you have done exactly. And descriptive anatomy is a situation in which you pick up a particular territory, a particular vessel, and then you talk about the branching patterns, you talk about the relationships with other structures, you talk about the supply. The other way of understanding anatomy is to look at what we call as regional anatomy. So as clinicians and as neuroendovascular explorers, we need to understand what are the basic regions that are supplied by all these vessels that you have been discussing. Now,
you can unshare yourself. Rohit?
Yes,
Rohit,
sir.
Yeah, Rohit, could you hear me?
Yeah,
Yes, sir. Yes, sir.
Yeah, go ahead. Go ahead, Rahul.
Sir, could you hear me?
Yeah, very clearly.
Yeah. So what I'm trying to say is, rather than going descriptive about the anatomy, what we should try to do is we should try to understand the regional anatomy. For example, whenever we talk about the external carotid artery, we tend to talk about zones. For example, the external carotid territory is divided into 5 distinct zones. You have the CV junction, you have the maxillomandibular area, you have the nasal fossa, you have the fronto-orbital area, and then you have the pharyngo-occipital area. So whenever we start discussing anatomy in terms of region, we tend to understand better. For example, in one of the slides, Rohit mentioned that ascending pharyngeal artery has a role in epistaxis management. This is obviously inaccurate. The reference is completely inaccurate because in routine epistaxis, what we see at the posterior epistaxis, we have no relationship of that territory with the ascending pharyngeal system. That nasal vascularization comes from a different system. It is a completely different situation. So what I would request my students to do is they have to in fact, descriptive anatomy is very good. You should know it. But once you have understood the descriptive anatomy, maybe the next session can be we break the skull base, the external carotid territory into different groups, and then take up each of the groups and then discuss them, because this anatomy does not help us in the cath lab. We have not been able to discuss the hemodynamic balance between the various vascular territories. For example, even as far as the internal carotid system is concerned, I would prefer that we talk about the internal carotid system as, for example, only the carotid bulb is a part of the pharyngeal system. The remainder of the internal carotid artery is not a part of the pharyngeal system. So the inherent inadequacies of the pharyngeal system are seen in the carotid bulb. But when you go distal to it, you do not see those problems. For example, you will not find a carotid stenosis that spares the carotid bulb. At the same time, you will not find a carotid stenosis in the main trunk of the common carotid artery. These are extremely rare. You will find a dissection there, but you won't find atherosclerosis there. So all these things need to be understood in terms of hemodynamic regions. For example, for the internal carotid artery, I would prefer that we do a session on the cranial division of the internal carotid artery and a caudal division of the internal carotid artery, because that is going to help us when we try to understand the vascularization of complex lesions like dural fistulas and AVMs later. So this is my comment. Otherwise, as far as the descriptive part was concerned, it was very good. Some mistakes are there. You need to check your references. Make sure that your references are not Wikipedia references. They are very, very proper scientific indexed publications. That's all that I would like to say.
So Rahul, I think you have put things in perspective, and I think the internal carotid, external carotid anastomosis,
Yes, sir.
that also should be covered.
Yes, sir.
And yeah, that is also a very important aspect.
Yes, sir. So the moment we understand the 6 distinct regions, then we will have to explain where these 6 regions interact with each other. And that is where we have the anastomosis.
Right. So maybe next time somebody can cover that.
Yes, sir.
Yeah. Thank you, Rohit. You've done a good job.
Who makes these, who allots these presentations, sir?
I think Gigi decides.
Okay. So I'll have a discussion with Gigi and I'll tell him how exactly I want this to go forward. And I will create 5 or 6 topics so that he can allot it to specific people so that we cover the whole thing in a holistic way.
That is better, I think. Yeah.
Yes, sir.
So let's, as we are going now, let's go on with the anatomy and applied anatomy.
Yes, sir. Yes, sir.
And from there, we go on to the clinical things later.
Yes, sir.
Very good. And let's try and keep it every week as far as possible. Unless,
Yes,
of
sir.
course, something turns up. So let's
Yes.
try and keep it every week.
Yes, sir.
Yeah. Very nice. Thank you.
Okay. Very good, Rohit. Very good. Keep it up.
Thank you, sir.
Thank you.
Thank you, sir.
Good night. Good night to everyone.
Good night, sir.
So,